Welcome. Good morning, everyone. Welcome to Grand Rounds today. We have a real treat today with two of our own very esteemed faculty who I will introduce in 1 second. First, just wanted to announce next week's Grand Rounds is going to be Dr. Robert Sweet from University of Pittsburgh, who will be talking about risk and resilience to psychosis in Alzheimer's disease. So our Grand Rounds speakers today are Dr. Michael First and Dr. Geoffrey Reed, who will be presenting on why there are two classification systems in psychiatry and how they differ. Dr. First is a professor of clinical psychiatry at Columbia University and a research psychiatrist at the New York State Psychiatric Institute. Dr. First is the editor and co-chair of the DSM-5 text revision, editorial and coding consultant for DSM-5, and the chief technical and editorial consultant on the WHO's ICD-11 revision project. Dr. First was the editor in the DSM-4 text revision, the editor of text and criteria for DSM-4, and the American Psychiatric Association's Handbook on Psychiatric Measures. Dr. First has co-authored and co-edited a number of books, including the 4th edition of the 2-volume psychiatry textbook, a research addenda for DSM-5, the DSM-5 Handbook for Differential Diagnoses, the SCID-5, and Learning DSM-5 by Case Example. Dr. First has trained thousands of clinicians and researchers in the diagnostic assessments and differential diagnosis. So it's a real pleasure to welcome Dr. First. I also wanted to introduce Dr. Geoffrey Reed. Dr. Reed is professor of medical psychology and scientific co-director of the Global Mental Health Program in the Department of Psychiatry at Columbia University. Beginning in 2008, Dr. Reed served as Senior Project Officer for the development of ICD-11 in the WHO. He's currently a member of the Medical and Scientific Advisory Committee for ICD-11. Dr. Reed founded the WHO Global Clinical Practice Network, which now comprises over 16,000 mental health and primary care professionals from 160 countries, and contributed directly to the development of ICD-11 through field trials. Dr. Reed has received numerous awards, including an award from our own department, the Robert Spitzer Memorial Award for Outstanding Contributions to Nosology. He's also received the Outstanding International Psychologist Award from the Division of International Psychology at the American Psychological Association. So with that, it's a real pleasure to turn it over to Dr. Reed and Dr. First.
Okay, welcome everyone. So this is a special lecture where both Dr. Reed and myself are going to be kind of doing a back and forth, even though I have more familiarity with obviously the DSM and Jeff with the ICD. We're both going to be talking about different topics and giving both perspectives. So we'll be jumping back and forth from me to Jeff and then back again. So next slide. Next slide again. Okay, so I'm going to start just giving you a little background. Just the DSM, we're up to DSM-5, and ICDs, you'll see we're up to ICD-11, just to run through very quickly the history. So DSM first started in 1952, and that was the first one the American Psychiatric Association put out. And unlike the DSMs we're familiar with, there were just simply one paragraph definitions for the disorders. DSM-2, which was in 1968, was the first edition to incorporate the ICD diagnostic codes and structure. And this is important because this is when the two systems first came together. And in fact, DSM-2 and ICD-8, which was the corresponding one, were essentially the same. So DSM-3 was the first edition with diagnostic criteria that was developed by Bob Spitzer. DSM-3R, which was at 87, which was the first edition that actually included an appendix for proposed categories. DSM-4 in 94, and that was the first one when there was a real emphasis on the review of the empirical literature. The DSM-4 text revision in 2000 was the first edition where the goal of it was revising the text. And finally, the most recent DSM came out in 2013, and it's highlighted by its focus on the dimensionality of disorders. Next slide. Now, the ICD version, you'll notice right from the beginning, rather than starting with ICD-1, the ICD history really starts with ICD-6 because prior versions of the ICD were just mortality classifications. The first version of ICD that had morbidity, and which was also the first version that actually included mental disorders, was ICD-6 in 1948. And then ICD-7 was in 55, and there was almost no changes. ICD-8 was the first time that you're probably familiar with the fact when you submit a claim, you have to write down an ICD code. So ICD-8 was the first version of the ICD where the US government started requiring the use of the ICD. And ICD-9, the system that you probably have heard of is the ICD-9-CM. That was the coding system up until a couple of years ago that you all had to write down when you were submitting codes. And that was created by the National Center for Health Statistics to expand ICD-9 for clinical use in the United States. ICD-10 came out in 1990, and this was the first version that had alphanumeric codes, which is a combination of obviously numbers and letters. And the reason they did that is they were basically running out of codes in ICD-9. So this expansion by adding letters expanded the number of codes from 17,000 to 55,000 codes. And it was also the first version to include clinical descriptions and diagnostic guidelines, which is really analogous to the DSM criteria. And finally, to bring it up to date, the most recent version of ICD, ICD-11, was actually just approved by the World Health Assembly in 2019, and it was specifically developed for electronic implementation. And even though this was approved in 2019, it's up to the individual member states of WHO to decide when they're planning to put them into effect. Next slide. So there are two systems, obviously, that's what we're here. So the systems have lived side by side. So there has been obvious attempts and discussions to what could be done to bring them together. And DSM-2, there actually looked like there was only going to be just one system. DSM-2 in the introduction specifically said that DSM-2 reflects the growth of the concept that people of all nations live in one world. And the time has come for US psychiatrists to collaborate in preparing and using the new ICD-8. I mean, there's really no reason. We're all human beings. We all have kind of the same mental disorders. There's no need really for two classifications. And I think that was what happened in DSM-2. They realized that. But then in 1980, when DSM-3 was being produced, as I mentioned before, it was the first version to have diagnostic criteria. Bob Spitzer, when he was putting ICD together, basically said, it's more important for us to be able to use diagnostic criteria than to have a single classification internationally. So that created the initial split between the DSM-3 and the ICD-9. Next slide. So DSM-4, which came out around the same time as ICD-10, they were continuing the idea that there was going to be a separate ICD in the DSM. So at least to try to minimize the differences, ADAMHA, which is the US Agency for Mental Health and Drug Abuse, sponsored meetings with the work groups between the DSM-4 and the ICD-10 to reduce the differences. And there's an analysis of all of the criteria and definitions of DSM-4 and ICD-10, and basically only one disorder, transit tic disorder, was defined identically. So despite this, there's continued to be, most of the changes were minor, but there's still, when you have two groups working separately, you're going to have two different versions. Next slide. So the current situation, DSM-5 came out in 2013, ICD-11 has just come out now. So this is what went into the harmonization of the current versions. So basically there was a joint committee of WHO and APA people who actually focused on developing harmonization. And what was basically harmonized was the structure, what they call it the meta structure. It's the way the disorders are grouped together and how they're laid out. So that's probably the big success of harmonization, not so much on the disorder level. To try to enhance the harmonization at the disorder level, a lot of the DSM-5 work groups have people from ICD-11 on the committees and vice versa. And although the organizational structure is largely harmonized, there are a lot of differences still between the two systems. And a number of them are intentional. Like one of the big differences that's been around for quite a long time is schizophrenia in ICD-10 is 1 month and 6 months in DSM. And that was done on purpose. They have a different sense of how it should be. Next slide. So it's very, very clear that we can do harmonization, but they'll never, ever be the same. And this is among the reasons why they will never be the same. First of all, it would require either WHO or APA to say, okay, we're done. You're now in charge of classification. WHO can't do that. They're mandated to do international classification for all of medicine. So that's not even an option for them. APA theoretically could decide to close down the DSM and just adopt ICD, but the APA chooses not to. Among the differences between the two systems, which will keep them from ever being the same, is the fundamental goals and the priorities of the APA and the WHO are different. WHO, as you might imagine, would prioritize public health and the collection of health statistics, because that's what WHO was founded to be, where DSM was really designed by APA for use by psychiatrists in the US. If other mental health professionals want to use it, fine, but the top priority is among psychiatrists in the US. And because of that, there have been several examples where the needs of the APA have trumped scientific considerations, where again, for WHO, the public health and the needs of member states are the primary considerations. Next slide. Okay, so so basically for this presentation, we're going to focus on 4 different areas where DSM-5 and ICD-11 ended up being different because of different decisions. And we'll highlight the reasons why, and you'll see some of the themes about the kinds of things that would keep them separate. So I'm going to start by turning this over to Jeff, who will cover the first part, which was severe childhood irritability and anger.
Thank you, Michael. So, sorry, I haven't spoken a lot yet today. There was a problem that had to do with some children who exhibit severe and persistent irritability and temper tantrums to the extent that they become unmanageable at home or in school. And some of these children were had severe enough disturbances that they needed to be hospitalized. There was no diagnosis in either the ICD-10 or the DSM-4 that clearly provided a diagnostic home for these children. And as a result, many were misdiagnosed. And it seemed like the most popular misdiagnosis was to diagnose them as having pediatric bipolar disorder. And as a result, they were inappropriately medicated and otherwise treated in less than ideal and effective ways. So both DSM-5 and ICD-11 realized this was a problem, but they adopted substantively different solutions to it. DSM-5 has added a new mental disorder, disruptive mood dysregulation disorder, or DMDD, and ICD-11 has rather added a specifier for oppositional defiant disorder with chronic irritability and anger. And I just want to comment that in ICD-11, the specifiers have to be coded. So there is actually a different code assigned to this. If you're used to the specifiers in DSM, there's usually no way to code them. So it's just, it's something for the clinician's record, but here it will be something that you could use for health statistics. So how did this happen that all these kids ended up being misdiagnosed as having bipolar disorder? There was really a kind of movement in the United States that began with Wozniak and colleagues in 1997 proposing that chronic irritable mood could be considered a developmental variant of childhood onset mania for the purpose of diagnosing pediatric bipolar disorder. That idea was further validated by a roundtable held by NIMH in 2001 that also concluded that prepubertal children could present with a form of mania that would be characterized by chronic severe irritability, affective storms, mood lability, severe temper outbursts, poor concentration, and impulsivity, with or without clear episodicity. So, this sounds a lot like what we are calling today DMDD. At that time, after that, there was a huge explosion of interest in bipolar disorder among children in the United States. There was a dramatic increase in publications here. 5 publications related to pediatric bipolar disorder had appeared prior to 1980, and then there were 27 between 80 and 89, 50 between 1990 and 1999, and 227 from 2000 to 2005. So you can see this kind of logarithmic growth of interest in terms of the research literature. There was a corresponding surge in childhood bipolar diagnoses by children, such that, for example, bipolar disorder was the most common diagnosis in hospitalized children under the age of 12 in 2004, according to data from the CDC. There was a very influential study by Moreno et al. That came out in 2007 that showed a huge increase in the rates of bipolar diagnoses in children in the National Ambulatory Care Survey. There were 25 such diagnoses per 100,000 visits in 1994 to 1995, and that rose by more than 4,000% to 1,005 per 100,000 visits in 2002, 2003. There were also at the time a lot of books that became very popular. On the left, you can see the cover of a book that's actually designed for children that's called My Bipolar Roller Coaster Feelings Book. And on the right is a book for parents called The Bipolar Child. So it was very much a movement that was a popular one as well. Inevitably, then, there was a backlash to this against overdiagnosis and overmedication of children. You remember that there was a story in the New York Times, and a controversy ensued about kids who were being inappropriately medicated. Particularly, this is somewhat typical of a statement about that time. Alan Francis in 2016 wrote, "For ADHD and kiddie bipolar drug companies misleadingly and aggressively sold the ill to peddle their expensive and profitable pills. Their marketing strategy was based on the cynical assumption that starting a kid early on pills might make him a customer for life." And that was the attitude that kind of pervaded the response eventually. It also really seemed to be a specifically US problem. So there was a study by James et al. In 2004 that found a more than 72-fold difference in discharge rates for pediatric bipolar disorder in youth between the US and England. So in the US, there were 100 per 100,000 population. In England, there was only 1.4 per 100,000 population. After controlling for cross-national differences in length of stay, the discharge rates for pediatric bipolar disorder remained more than 12 times higher in the US than in the UK, than in England. It became clear that really there needed to be a diagnostic alternative for this particular group of children. And even though bipolar disorder is known to occur in children, most of the kids who were misdiagnosed as having pediatric bipolar disorder didn't actually meet the criteria for bipolar disorder. So a group of researchers at NIMH, led by Ellen Liebenluft, began to investigate a syndrome called severe mood dysregulation, or SMD, which seemed to better describe the symptoms seen in these children. So the initial research was really looking at this phenomenon of SMD in relationship to bipolar disorder. SMD was found to predict anxiety and depressive disorders, but not bipolar disorders in adolescence and adulthood. Eventually, the research syndrome of SMD was adapted and became the DSM-5 diagnosis of DMDD, which was placed among the depressive disorders. However, in that adaptation, the core symptoms were substantially changed. So, you could say accurately that DMDD had not been subject to peer-reviewed research prior to being proposed for inclusion in the DSM-5. When field studies for DSM-5 were done, they showed low reliability in outpatient settings and very high rates of overlap with other disorders. So why was it included in the DSM-5? One factor was that it was presented as a solution to the misdiagnosis of pediatric bipolar disorder and related overmedication. Members of the work group argued that it was urgent to include DMDD in order to be able to provide urgently needed help to this nosologically homeless population and to facilitate further research, in spite of insufficient evidence to meet DSM standards for adding a new disorder. So DMDD was also proposed for inclusion in ICD-11, and this is what happened. The ICD-11 Childhood Disorders Working Group member, Danny Pine, proposed DMDD for inclusion in the ICD-11, but the ICD-11 Working Group was unconvinced. The proposal was referred to the Working Group on Mood and Anxiety Disorders, which was chaired by Mario Mai, and Ellen Liebenluft was actually a member of that working group. The Mood Disorders Working Group rejected the proposal based on insufficient evidence for the validity of the condition. So it was a very different response that it received in the ICD-11 environment. One thing that the ICD-11 perspective really emphasized was that the vast majority of children who would be diagnosed with DMDD also met the diagnostic requirements for ODD, or oppositional defiant disorder. ODD is also predictive of mood and anxiety disorders in adolescence and adulthood, and a substantial subgroup of children with ODD exhibit chronic irritability and temper outbursts. So these facts really suggested that the most parsimonious solution would be to develop a subtype of ODD that was characterized by chronic irritability and anger, which is eventually what happened in the ICD-11 system. So when you look at what happened with this, the take-home messages are that APA became very quickly committed to the idea that the best way to address the misdiagnosis of this group of children and related over-medication was by providing a new diagnosis. And that led to inclusion of DMDD without sufficient evidence to meet APA's own evidentiary standards for new disorders. Whereas in ICD-11, creating a new disorder was not viewed as the appropriate solution, partly due to the international focus of ICD-11 and the perception that this was really a United States issue. So you have two different solutions, and they both seem to be viable and defensible for a different set of reasons, and time and additional research will tell which of those two solutions is superior.
Okay, so the next example is compulsive sexual behavior. And this shares in common with the DMDD example that there's a hole in the system. You know, the fact that there are individuals with excessive sexual drive and excessive sexual behavior has been recognized for a very, very long time. And you know, categories like Don Juanism, nymphomania, and compulsive masturbation, which was mentioned in DSM-2, they weren't actually categories, but they were inclusion terms, have been there. So this idea that there are individuals who have this hypersexuality has been a problem, but there's never really been a category. And since the DSM and the ICDs have always had these other specified categories, there's always a home for those people, but not a specific home. So in the DSM world, starting in DSM-2, going all the way up to DSM-4, there's a category called sexual disorder NOS, which was the residual category for the sexual problems. And the DSM commonly lists things as examples. So if you actually pull out a DSM-4, you'll see this phenomenon listed as an example of the kinds of things that would qualify for sexual disorder NOS. DSM-3, I just pulled this out because they actually explicitly use the phrase sexual addiction to describe this. So you can see already there's some lack of clarity about exactly what this is. ICD-10, it first introduced the concept of excessive sexual drive, but this wasn't an inclusion. This was actually a category with its own code in ICD-10. So going into DSM-5 and ICD-11 was the question, can this thing be made into a category so that it could be defined clearly and used with actual patients? So next slide. So DSM, so this is another example of two different approaches to trying to solve the problem of what do we call these individuals. So DSM, the sexual disorders group, actually it was the paraphilia group, came up with this idea of having a category called hypersexual disorder. So it's basically conceptualized as sexual desire disorder, which is characterized by increased frequency and intensity of fantasies, urges, and behaviors, and enacted behavior that's associated with an impulsivity component, meaning that it came out relatively as an impulse, and it had adverse consequences. So next slide. So from the beginning, it was sort of conceptualized kind of like an addiction. So just to give you a small example, here's two criteria from the proposed hypersexual disorder: repetitive but unsuccessful efforts to control or significantly reduce these fantasies, urges, or behaviors, and repetitively engaging in sexual behavior while disregarding the risk for emotional or physical or emotional harm to self or others, which sounds very much like what dependence is like. And here are the corresponding criteria in substance dependence. There's a persistent desire, unsuccessful efforts to cut down or control substance use, or use of the substance continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the substance. You can see here what's emphasized really is this idea that there's a loss of control over sexual behavior and thoughts. Next slide. So one of the questions was, well, where does this go? If this were to go into the DSM, where would you place it? there is no category of sexual disorders. It's a category of sexual dysfunctions, and certainly having hypersexuality is not a dysfunction. It doesn't really fit anywhere. So this kind of shows you what part of the problem was. Exactly what this is not, still hasn't been really clarified. So for example, if you look at the literature on this excessive sexual drive, it's been reported as a compulsive disorder, impulsive disorder. So compulsive means you're sort of compelled to do this and can't control it. It's a loss of impulse control as an impulse disorder. It's been sort of characterized as a behavioral addiction, or as the DSM-5 work group did, considering it as a problem with sexual desire. And the problem is the data supporting each of these hypotheses were really insufficient to determine placement, which is really a red flag for trying to figure out what to do. So the proposal, though, from the DSM-5 workgroup was that it be included, a hypersexuality disorder, as a sexual disorder that was associated with increased or disinhibited expression of sexual arousal in association with a dimension of impulsivity. Next slide. So ICD-11, again, recognizing that there are individuals whose sexual behavior gets them into trouble, their inability to control it, is a thing out there. And for public health reasons, is there a way to describe it and be able to track it? So you can see right off the bat that the conceptualization is a little bit different from the get-go. ICD-11 sees this as a problem with sexual behavior. Hypersexuality was a excessive urges, thoughts, or behavior. So where the ICD-11 right from the bat, it's really the behavior that gets people into trouble more than the urges or desires. So it's basically a persistent pattern of failure to control intense, repetitive sexual impulses or urges, resulting in repetitive sexual behavior. And there are a couple of exclusions in the depth. So you would not give this diagnosis if the person has a high sex drive, but no impaired control. So it's not just one of the one of the problems is, what does it mean to have high? How much sex drive is too much? It's almost impossible to say. The only way you could begin to see this as a pathological condition is when the sex drive is such that it impairs your control over it and gets you into trouble. Now, individuals who have this, who have no distress or impairment, can't get it. And because high levels of sexual interest and behavior is very common in adolescence, this diagnosis is not given to adolescents. And the reason it was included in ICD is because it really was an important clinical problem, and it needed to be tracked for public health reasons. Next slide. So again, this is a summary of the differences between the DSM-5 and ICD-11. So again, the most important thing is that DSM-5 allowed this diagnosis to be given entirely if there were excessive fantasies or urges, no behaviors needed. Now, how this happens, imagine somebody who was so preoccupied with sexual fantasies that they weren't able to get their job done because they were just fantasizing. So that's how you can imagine an individual could have this version of it. But ICD-11 decided it really is the behavior that's necessary to be able to make the diagnosis. There was a criteria set. They had 5 different scenarios which were similar to the criteria for substance dependence. And several of the items emphasized that this excessive sexual thoughts could be a response to dysphoric mood states or distressful life events. On the ICD-11 side, they had a list of 4 different criteria, and you needed only 1 out of the 4. It is similar, again, kind of to dependence, where it becomes a central focus of the person's life. The person has made numerous unsuccessful efforts to reduce or stop. The person continues to do it despite adverse consequences. And one concept that was unique to ICD-11 was the idea that the person continues the behavior even when they don't derive any more enjoyment from it. It becomes just a pure compulsion. And the other thing about ICD-11, which is something which is also true for the paraphilias, is you don't give the diagnosis if, like DSM, ICD-11 uses distress often as the measure of when you consider something a disorder. But if the distress is entirely related to moral judgments and disapproval of others, then you can't give the diagnosis. It has to be distress from the individual. So the ICD is trying to remove negative context as a source of distress. It's really calling something a disorder. Next slide. So what happened? I mean, I guess it's not in the DSM. So basically, hypersexual disorder was not approved, and it vanished from the DSM without a trace. And what I mean by without a trace, there were a couple of ways to put hypersexual disorder in the DSM-5. One was the fact, okay, so hypersexual disorder, it's very clear that the the empirical evidence supporting it was perhaps not strong enough to include it in the classification. And that's what there's a DSM appendix is for. There's a long history of if there's a proposed disorder that is on the face of it potentially reasonable, but there's insufficient evidence to put it in, you put it in this appendix called Conditions for Further Study, but it was not put there. And it wasn't even listed as an example of an other specified category, unlike it being listed for DSM-2, 3, 3R, and 4. But so it's literally not, and it's really not clear where you have people see patients like this, and it's not obvious where to put it. It's basically, the recommendation is there is a category called impulse control, conduct, and disorders other specified. So that's where it would go, but that's a pretty not an obvious place for it. Whereas in ICD-11, it was accepted as a disorder and it was placed in the impulse control disorder section. Next slide. So what are the take-home messages? This is a good example of the different focus and the different prioritization. So WHO is most concerned with the public health needs of the classification, and this is viewed as a true public health issue. They felt that they needed to put it in there. And plus, there's no option in ICD-11 to put it in the research. There's no research appendix. So it's either in or out. And it was considered an important enough public health problem, even though the amount of the empirical data wasn't maybe as much as people would like, but because it was an important clinical problem and a legitimate focus of treatment, that was enough for it to go into ICD-11. Now, so why was it vanishing without a trace? Well, it appears to be that APA is partly because it is a professional organization and representing the needs of the profession. They're very sensitive to what it looks like to put excessive sexual drive. There's been a lot of people like Tiger Woods, people who've used I'm a sexual addict and trying to get off because of that. So there's a lot of negative view among the public and people about the idea of having excessive sexual drive or hypersexuality as a disorder. So they were so concerned about trying to defend this decision that, and avoiding political blowback, they basically excise it completely from the book. So that's kind of one reason why there's a different outcome. I think next. Go to
yes, so I'm going to talk about personality disorder. I'd like to start with some background on personality disorders in the DSM-5. A research agenda for DSM-5, which came out in 2002, included a chapter that specifically aimed to pave the way for a dimensional model of personality disorder. There were a number of dimensional models of personality and personality disorders that had been developed. They were conceptually similar, but had somewhat different dimensions with different names. For example, there was the NEO 5-factor model, which is often referred to as the Big Five, the dimensional assessment of personality pathology, or DAP, and the schedule for non-adaptive and adaptive personality, or the SNAP. So a big challenge for DSM-5 was to think about whether to adopt an existing model, even a potentially proprietary one, or to develop a new one. There was a series of planning conferences that were jointly arranged by APA and WHO that provided some of the initial basis for thinking about how to structure the DSM-5 effort. The first one was held in 2004, and it focused on strategies for developing a dimensional model of personality disorder. So it was really widely anticipated and almost a foregone conclusion that DSM-5 was going to have a dimensional model of personality disorder. There was a big desire in the development of DSM-5 to switch to dimensional models of psychopathology, and personality disorder was really seen as the best place and the most obvious place to really start with that. So what happened? There's an oral history that's pretty interesting. I put the reference for it here by Zachar, Kruger, and Kendler about personality disorder in the DSM-5 that was published in Psychological Medicine. You can sort of read there all the gory details, but basically a consensus on a single dimensional model didn't emerge. And in response to this debate and lack of consensus, Andy Skotal, who's the chair of the personality disorders work group, proposed a compromise hybrid model. And the hybrid model assigned an overall personality disorder diagnosis based on the presence of deficits in self and interpersonal functioning, plus the presence of pathological personality traits, and then used a prototype matching approach which had been written about by Drew West, and in particular, to identify 5 specific personality disorders. And I want to show you an example of what prototype matching looked like. So here's an example of a prototype for narcissistic personality disorder. So it says, individuals who match this prototype have fantasies of unlimited success, power, beauty, talent, brilliance, and so on. They appear to feel privileged and entitled, and they expect preferential treatment. They have an exaggerated sense of self-importance, and believe they can only be appreciated by or should only associate with people who are high status, superior, or otherwise special. Individuals who meet this prototype seek to be the center of attention and seem to treat others primarily as an audience to witness their own importance. And it goes on from there. This is just about half of it. So what the clinician does is to provide a dimensional rating from 0 to 5. So 0 would mean that the person doesn't match the prototype at all, and 5 would mean the person is completely accurately described by the prototype, of the degree of match between the patient and the written prototype description. It is purported to resemble more closely the cognitive process that clinicians use to actually make a diagnosis. So the idea is that, following a certain amount of clinical experience, you develop mental prototypes and you match new patients in your mind to the prototypes that you have developed based on your clinical experience. There was, in response to this proposal, quite a bit of controversy. There were letters written and publications saying that the proposal was too radical and not useful for clinical practice. And the degree of controversy was such that APA felt like they needed to do something. They formed an advisory committee that was essentially a kind of a subgroup of the personality disorders committee to review the situation. And this advisory committee proposed a modified hybrid model, which replaced the prototypes with criteria. This new hybrid model was actually rejected by both of the DSM-5 oversight committees and appeared to be on track for a lot of opposition from the APA assembly. So what happened out of all that is that the hybrid model, this modified hybrid model, was eventually included in section 3, or the research appendix. And as a result, the main classification of DSM-5 retains the general personality disorder criteria plus the 10 specific personality disorder categories in a way that is completely unchanged from DSM-4. So, ironically, this area in which there was really the best hope for making a switch to dimensional diagnosis in the official classification didn't turn out that way at all. The alternative model, I want to say a little bit about what it is, because there obviously is considerable interest in this. And by calling it the alternative model, it makes it seem as though people can use this instead, and that would be perfectly acceptable. So to be diagnosed with a personality disorder under the alternative model, which is a hybrid of a dimensional and categorical approach, the patient has to have moderate impairment on at least 2 of 4 areas of personality functioning, which are identity and self-direction, which is the self-functioning part, and empathy and intimacy, which is the interpersonal part. There needs to be a significant elevation on at least one of the 5 personality trait domains, which are composed of 25 facets. These are negative affectivity, detachment, antagonism, disinhibition, and psychoticism. And then 6 personality disorders are expressed in terms of specific patterns of impairment in personality functioning traits, and these are those. So you have to go through this very complex process of first assessing the personality functioning in terms of self-functioning and interpersonal functioning, assessing the personality traits, and then matching those in terms of criteria to the 6 personality disorders that are included. And then if you've decided that somebody has a personality disorder but doesn't fit one of those 6 patterns, you can still assign the personality disorder diagnosis, and you just describe it in terms of the traits and characteristics they have. This is an interesting theoretical model, I think. And if you look at the alternative model, the way it's written in DSM-5, it looks like, to me as a psychologist, it looks like a model for assessment. But it seems really unwieldy, like very difficult to actually implement in clinical practice for a clinician who is going to try to approach this, particularly without specific measures that help them to make this decision. The ICD-11 Personality Disorders Working Group was formed in 2010 and included a specific liaison from the DSM-5, who was Leanna Clark. The WHO had already from the beginning indicated to the working group that WHO considered the categorical system of personality diagnoses to be fatally flawed. There were problems with validity, there were problems with implementation. Only 2 of the categories had any evidence of being widely used. There was stigma, co-occurrence problems, and stability problems. So WHO also asked the work group to explore dimensional models, and especially to consider the use of dimensional models that they might recommend in non-specialist and low resource settings. And the working group of WHO had the benefit of learning from the struggles that were being experienced by the DSM-5 work group. So the initial proposal for ICD-11 was to eliminate all of the specific personality disorder categories and instead to focus on severity. And the definition of severity initially was based entirely on the degree of interpersonal disturbance and the risk of harm to self or others. There were trait domain specifiers included, but they were described as optional and for settings with sufficient resources and expertise to be able to assess them. And the idea was that in primary care or low resource settings, you could only just do the severity part of it, and that would be about as much as you could expect that they would do. There were extensive descriptions of these proposals published in The Lancet, this article that Peter Tyrer was the first author on in 2015, as well as in more specialized journals. And there were presentations at numerous scientific meetings about the model. And, not surprisingly, there was significant pushback about the proposal. And the biggest controversy was really had to do with the elimination of borderline personality disorder. So I went to some meetings and there were some people that just really were angry about, WHO throwing away, 50 years of research on borderline personality disorder. And a lot of clinician opposition began to be stirred up as a result. Eventually, there was a letter of concern circulated by the European Society for the Study of Personality Disorders and the International Society for the Study of Personality Disorders to their entire membership. This letter was actually addressed to me, but somehow they sent it to the wrong email address, so I didn't get it. And so what happened was I started hearing from my friends, have you seen this letter that's written to you? The letter expressed substantial concern about the elimination of borderline personality, but also the view that the proposal provided insufficient information about the nature of individual personality disturbance to support case conceptualization, treatment selection, and management. So, being in the position to kind of decide how WHO would manage this, I felt like we couldn't really go forward with a proposal while we were ignoring the feedback that we were getting from major international research societies about the nature of their objections to the proposal. So we met with the representatives of these organizations, as well as the North American Society for the Study of Personality Disorders, to discuss their concerns. And eventually we set up a special kind of task group that consisted of representatives of these organizations and representatives of the WHO working group who worked over a period of several months in regular meetings to discuss how to modify the proposals to address the objections of these primarily researchers, but they were clinician researchers often. And that culminated in a 2-day meeting in September that we had in Heidelberg to rewrite the guidelines to address their concerns. It turned out that the organizations were really willing to accept the dimensional system, but substantial changes were made to the diagnostic guidelines. So one was systematic incorporation of self-functioning, which had really been left out of the initial severity model, and richer and more clinically informative operationalizations of severity and trait domains. We also agreed ultimately to provide an optional specifier for borderline pattern. Some of the hardcore dimensional theorists were really pissed off about this because they feel like it just kind of wrecked the whole model and defeated the whole purpose of going to a dimensional model. But it also became clear that as a practical matter, the proposal wasn't going to be able to go forward without making this concession. So it was sort of a pragmatic decision in order to be able to move the proposal ahead. Eventually, the working group, the WHO advisory group, and the Personality Disorder Research Societies all signed off on the revised guidelines. This is the information that is included in the guidelines about the borderline pattern specifier. It says it's been included to enhance the clinical utility of the classification of personality disorder. There is considerable overlap between this pattern and information contained in the trait domain specifiers, most typically negative affectivity, dissociality, and disinhibition. However, use of this specifier may facilitate the identification of individuals who may respond to certain psychotherapeutic treatments. And this is really the most compelling aspect of this argument that borderline should be contained, is that coverage for certain kinds of treatments had been hard won over a period of many years to allow people with borderline personality disorder to receive relatively intensive forms of treatment, and the risk was that this opportunity would be taken away. So WHO's position was whether this specifier would provide eventually information that was seen to be non-redundant with the trait domain qualifiers was an empirical question and something to be addressed in further research. So the personality disorder diagnosis in ICD-11 looks like this. You first assess the general personality diagnostic requirements, which do also have primarily to do with self and interpersonal functioning, but also with behavioral and cognitive and emotional manifestations of personality disorder. If you decide that the person meets the general diagnostic requirements for personality disorder, then you assess severity. And severity is actually the basis for coding. So these are the diagnostic codes. So there's a code for mild personality disorder, moderate personality disorder, and severe personality disorder. And those are all operationalized in particular ways. And then there's an assessment of the personality trait domains that are relevant to the particular disturbance. And then if applicable, you assign the borderline qualifier. This approach is really compatible conceptually with the with the DSM-5 alternative model. So where I've put the asterisk is to indicate that those same things occur in the alternative model, but what you don't have is this process of matching it to particular categories of personality disorder, which I think makes it much more complicated. This is a comparison of the trait domain areas in ICD-11 as compared to DSM-5. Both include negative affectivity, which is the tendency to experience a broad range of negative emotions. Both include detachment, which is the tendency to maintain interpersonal and emotional distance. Both include this same dimension, which refers to disregard for the rights and feelings of others, among other things. But in ICD-11, this is called dissociality, and in DSM-5, it's called antagonism. Both contain disinhibition, and the two ways that they're different is that ICD-11 contains this trait domain called anacastia, which refers to a narrow focus on a rigid standard of perfection and right and wrong for oneself and others, and would be the primary trait that would be characteristic of people who we would have said had obsessive compulsive personality disorder. In DSM, this isn't viewed as a separate domain. It's really viewed as the other end of disinhibition, which I think is theoretically a possible way to talk about it as well. But ICD-11 felt that this was clinically useful. Psychoticism is not part of the ICD-11 model because schizotypal disorder has been in the classification of schizophrenia spectrum disorder since ICD-10 and is not considered to be a personality disorder. So take-home messages here, ICD-11 has been able to implement a dimensional system as part of the official classification. My take on it is that researchers generally accept the ICD-11 system as a reasonable, if imperfect, starting point that will be modified over time, for example, whether or not the borderline specifier gets retained. Until we begin actual implementation at country level, even though we've collected a lot of feedback and done some field studies, we're not really going to know about clinician acceptability until they're told they have to use it. And the rollout of the ICD-11 will take place over the next several years, depending on what countries decide about how they will manage the rollout. And so when clinicians have to use it is when the rubber is really going to meet the road about whether they'll be able to do it or not, and whether they'll accept it. Dimensional systems, one thing about them is that they really require measures. So one good thing is that these are being developed at a good pace for ICD-11 personality disorders. So hopefully by the time that most clinicians actually have to do this, there will be measures in place that will help them to assess the constructs that are included in the classification of personality disorder. So back to Michael, I think.
Okay, so next slide. So I'm going to be focusing on differences in the disorders due to substance use. And this is interestingly each of the other ones, most of them had to do with, so the first two had to do with a hole in the system, and DSM and ICD having different approaches to try to fill that hole. Personality is an example of really two completely different approaches to how you do it. And it ended up pretty similar, but for a number of reasons, the DSM approach got scuttled and thrown in the research appendix, and the ICD became part of the system. So this one is interesting because dependence was in both DSM and ICD, and they were very similar. And this is one of the few instances where instead of making the two systems closer together as we move along from 4 to 5, they've actually less aligned in DSM-5 and ICD-11. So if you look back at DSM-4 and ICD-10, they both included a category called substance dependence, and it was characterized by impaired control and physiological dependence, as well as having non-dependence categories. DSM-4 had a category called abuse, and ICD-10 had a category called harmful use. Next slide. Just to show you what the matchup was. So they're very similar. They both had the same threshold, 3 in 12 months. And you can see how they basically all match up. They ended up with there are only there's one fewer items in the ICD-10, but they're essentially the same, which is this is the kind of thing, this shows you what are the advantages of having the same definitions, because these diagnoses were almost interchangeable. It really was very easy to do studies and use either one. Next slide. So for DSM-5, however, this has changed. So this will give you a little background of how this went. So DSM came out in 2013, but there was a pretty long lead up to DSM-5, which consisted partly of a bunch of conferences which were sponsored by NIMH, NIDA, and NIAAA, that in which the WHO and APA invited a number of experts in these different subject areas. Half of them were international and half were US, to focus on issues that they knew were going to come up for DSM-5 and ICD-11. So the third conference, which took place in February 2005, was focused specifically on substance use disorders. Next slide. So as a result of that initial conference in 2005, the recommendation was actually to keep substance abuse and dependence as separate categories. And the reasons for that was that dependence has a lot of clinical and prognostic implications. It indicated people were at greater risk for withdrawal. It predicts a more chronic course and harmful consequences. And a lot of the therapeutic guidelines for these diagnoses were based upon the individual having dependence. And plus, dependence has always been one of the most reliable diagnoses all the way through the DSM, and certainly true for DSM-4. Next slide. So what happened? So basically, this started unraveling when the work group was formed and started looking ahead about what they wanted to do. At the time DSM-5 preparation was underway, there were a lot of exciting new statistical techniques which were available, partly to help figure out whether things should be categorical or dimensional. So item response theory was a new technology that was really helpful to try to figure out which items should be part of the definition. So they had access to a number of data sets comprising over 200,000 individuals, and some of them were derived from clinical populations and some were general populations. And the results of the IRT analysis was that the criteria, when I think this is the criteria, both abuse, they took all of the criteria for abuse, the 4, and the 7 criteria for dependence, and added them up into 11. So that 11 item criteria set formed a single dimension. There was no separate dimension for abuse versus dependence. And another thing that this revealed is that even though you might think that abuse is a milder thing than dependence, when you actually look at the items and how they performed in the IRT analysis, it didn't quite work out that way. There were some items that were from dependence that were less severe than other items in abuse. So taking larger amounts of the substance than intended, which is a loss of control item, was less severe than failure to fulfill major role obligations. So individuals with much more severe cases would be more likely to have that item, whereas milder cases often have the taking larger item amounts of intent. So they could see that this split between abuse and dependence really, certainly from a statistical perspective, was and from a detection and measurement perspective, was really not the best. Next slide. So basically that resulted in a single dimensional approach. Now, another difference between DSM-5 and ICD-11 is the substance classes. So in DSM-5, to help, we group together substances based upon certain action, mechanisms of action into different groupings. And DSM and ICD have always aligned, but one thing I wanted to point out here is because ICD-11 is focus on public health implications, they have additional substance classes that were never added to DSM-5. So they separate as a separate class synthetic cannabinoids from cannabis because of evidence that it's becoming a huge problem internationally. And synthetic cannabinoids have a much higher risk and different kinds of risk than cannabis. So it made sense to have it as its own category. Next slide. Same thing here for amphetamines. So they have synthetic cathinones is its own separate category. So on the stimulant side, amphetamines and cocaine have always been separated, but this third version of stimulants was added to ICD-11. And then MDMA, which is its own category. MDMA in the DSM-5 is thrown into hallucinogens, but MDMA, ecstasy, is not exactly hallucinogen. It's somewhere in between the amphetamine and a mild hallucinogen. So really, it's become a big problem in the people abusing it. So it really got its own subgrouping. So this is again something that really highlights the public health emphasis of ICD-11. Next slide. So, okay, what happened with DSM-5 is that they have a category now called substance use disorder. There is no longer dependence and no longer abuse as separate categories. And the substance use disorder category has 11 items. And those 11 items are made up of all seven of the DSM-4 dependence items, 3 out of the 4 DSM abuse items. The item that was not included was substance-related legal problems that really performed much worse than the other items. It also had the problem that it was very situation-specific. What's legal in one area and part of the country is not necessarily legal in others, so it really didn't perform well. And they added a new item that was not in either dependence or abuse called craving, which so it's a new group of 11 items. And they, rather than having 2 separate diagnoses, you can now give the severity of substance use disorder as mild, moderate, and severe. And that's totally based upon counting up the number of items. 2 or more items is mild, 2 items or less is mild, 4 or less is moderate, and 6 and more is severe. Now, the problem with doing this is it's very, very heterogeneous. If you only need 2 out of 11 items, there are over 2,000 combinations of these symptoms, separate combinations that come out of this. So it's very, very easy to have 2 individuals who have a diagnosis of mild substance use disorder that look completely different because they have a different set of items. Next slide. Now, ICD-11 continue to have dependence, and I just wanted to make this. I'm mentioning this because the ICD-11. So DSM got rid of abuse, but ICD-11 not only did it retain this concept of harmful use, they expanded it. So ICD-10 had harmful use as a category. ICD-11 is split it between an episode of harmful use and a pattern of harmful use. And this is in ICD-11 because it's really important for public health reasons. It's defined as substance use that has caused damage to a person's physical or mental health, or has resulted in behavior leading to harm to the health of others, self or others. So this is not abuse. People often say, oh, well, this harmful use is equivalent to the DSM abuse. This actually requires damage. So it's a real public health issue. You're not at risk for a problem. You actually have a problem, which is caused by a substance. And it's been part of ICD-11 because it's intended to facilitate early recognition and intervention for substance use problems. And it was viewed as critical for capturing the public health impact of substance use in morbidity and mortality statistics. Next slide. So the concordance, so forgetting, obviously, getting rid of abuse and dependence, now that there's a substance. So it wouldn't make sense to just compare substance use disorder, which is 11 items, to dependence. In the DSM, mild and moderate and severe is considered to be equivalent to dependence. So this is a comparison between DSM-4 dependence, ICD-10 dependence, and ICD-11 dependence. They all have very, very high agreement with a kappa of 0.94 or above. If you wanted to figure out the concordance between DSM-5 and ICD-11, if you just use cases of moderate and severe use disorder, as with and compared to ICD-11 dependence, you see there's a much, much lower concordance. So that shows how different the two systems are. And it basically suggests that ICD-11 and DSM-5 are really identifying different individuals as having the disorder. Now, which of these two systems is more valid? Not yet, no. Next slide. So why did DSM-5 go in a different direction? One of the big reasons is from the very beginning of the work on DSM-5, there was a real push to make the system as dimensional as possible. If you look at the very early writings, there was a fairly sweeping claim that DSM was going to be much more dimensional than DSM-4, and they basically dimensional as opposed to categorical. And and the reason for that is that it's well known that there really aren't cut points. There's no blur boundaries between disorders. It's very blurry, and since there are no valid cut points and lack of clear boundaries, that supports the idea of having a more dimensional approach. And it's also been proposed that one of the reasons perhaps that people have been unable to validate DSM categories with respect to biomarkers was really because it's due to its categorical nature. And that is one of the founding reasons behind the development of NIMH's RDoC, which is a completely dimensional approach. And the thinking of perhaps the failure of DSM comes from the fact that it's a categorical system. So because of that, when work started on DSM-5, the work groups were really encouraged to move in that direction. Next slide. So there's been this, given all of that push in the DSM-5, this dimensionality really only manifests itself in a couple of different areas. Certainly the one I just mentioned, substance use disorder, they were very happy to have substance use disorder become dimensional because it really fit in with the agenda of the DSM-5 task force to make things more dimensional. Autism spectrum disorder, which is also a new addition to DSM-5, replaced 3 different categories: autistic disorder, Asperger's disorder, and childhood disorder into a single dimension of autism spectrum. So that fit and moved towards dimensionality. And the other 2 examples of dimensionality in the DSM-5 was getting rid of dementia and instead having a dimension of neurocognitive disorder with major neurocognitive disorder and mild neurocognitive disorder. And then the thing that Dr. Reed just talked about, the whole push to go dimensional from the beginning with personalities disorder came from this dimensional push. Next slide. So what happened here? So again, what's the take-home message to explain this difference? Well, certainly the DSM-5 dimensional aspirations led them to prioritize having a dimensional view of substance use over the retention of dependence and abuse, despite the fact that the clinical utility of having a dependence category was well established. So he basically said, it's more important for us to have a single dimension than to retain a category, which was actually considered to be very, very useful. So you basically sacrifice clinical utility in favor of this having a more dimensional approach. The next slide. Okay, so on the last 2 slides, I'm going to summarize by just, now, one of the points here is one of the advantages of having 2 systems. There's kind of an implication when I'm talking that it's really bad to have 2 different systems. There's no reason to have 2, but there actually are advantages. The fact that that DSM and ICD will probably never be the same. And among the advantages, it basically allows each classification to be optimized to meet the needs of their user groups. So ICD and DSM have different user communities and constituencies. So it allows ICD to make decisions to emphasize public health, and DSM to make decisions to emphasize its use in research settings. And also, one way to look at this is sort of a testing ground of, two different ways to solve a problem. Let's see which way is best. So having 2 separate systems with 2 different approaches allows us to add it to the system and then collect data, and that will help decide which one really is the best one. And it certainly supports the expansion of research and improvements of validity over time through convergent validation between the two groups, and also creates additional opportunities for developers of measurement tools and diagnostic instruments. Next slide. So how about the disadvantages? Well, the disadvantages are certainly having two systems makes things more complicated. If you have to, like in the US, even though the US is required to use ICD codes, in fact, the diagnoses are DSM diagnoses. They all have to be converted over to ICD. It also complicates the comparisons of results. This has always been a problem between having two separate systems. If you do a study using the DSM definition of a disorder, and a study in Europe is done using the ICD-10 or 11 definition of a disorder, even though they have the same name, you could get very different results because they're not the same definition of patient. So if they had one single way of defining a disorder, that problem would never happen. It certainly makes it different, complicates drug testing and approval. So as you know, every medication that's approved for use in the United States, as well as in Europe, has to have a drug indication, is usually based on a diagnostic category. So it makes it more difficult. So if the FDA gets drugs approved for the DSM versions of the category, so they apply as well to Europe, because European clinicians don't use those categories by and large. It also imposes an extra, the flip side, it's an opportunity, the differences for developers of measurement tools, but it also imposes an extra burden on the developers of diagnostic instruments. So we will stop here and open it up to questions. Thank you very, very much for your attention.
Thank you so much, Dr. First and Dr. Reed. That was incredibly illuminating and insightful talk. It's interesting. Psychiatric nosology can so quickly become dizzying and sort of remarkably contentious. And we are, incredibly lucky to have not just one, but two world experts in this area to help us think through this in a way that is both scientifically rigorous, but also clinically prudent. So thank you so much for your time and for your presentation. I guess I'll get us started with one question. So, in the discussion of dimensionality, you alluded to other classification systems, particularly RDoC, but there's others as well. There's the P factor that Terry and Moffitt are developing. There's the high top classification system. And I guess I was wondering if I could ask you to try to project out to the future a bit and speculate where are those classification systems going? Will they continue to exert greater influence over DSM and ICD, or what do you see happening with those systems?
Jeff, do you want to start with that?
Sure. Initially, when the NIMH first announced RDoC, they talked about it as though it was a classification system that had some kind of immediate prospect of replacing the DSM and the ICD. And of course, it's not really a classification system because it can't be applied by a country to assess, mental health conditions of a population. It's not designed that way, and it's not tested or fit for purpose in that way. What it is a framework for research. So what I think is, as those concepts get defined better and become more clear, and you see, particular neural circuits or particular, aspects of dimensions that map onto specific kinds of mental disorder categories, a task will be for DSM and ICD to think about how that will change the way that mental disorder categories are defined and operationalized. And I think probably that will mean a process of having to be open to updates that are more continuous and kind of in some way less paroxysmal. No, you're not going to change everything all at once, but you make the system open enough and permeable enough to be able to incorporate new knowledge as best you can as new knowledge emerges. I think I would say the same thing about high top. I think they don't really do themselves a favor by presenting themselves as like a competitor to the DSM or the ICD, because they're just not suitable for that purpose. And so the ICD and the DSM both have to be able to satisfy, what WHO calls use cases, where it's able to be used for particular purposes, and that's unique, and I think will continue to be.
Can I make a comment? The High Top Consortium actually does have a goal to replace DSM now, as soon as they understand that it's not there yet. And the main reason, again, it's clinical utility. They've been struggling to establish how you can actually use that in clinical practice. And if they could do it, they would do it now and say, let's get rid of the DSM. But there's the appeal of High Top is dimensionality. Feels like that's the way the world is. Things are on dimensions. So that's the big appeal. But the categorical systems thrive because they help people make decisions about treating patients. That's what they're there for. The dimensionality in High Top has already had some impact in the reorganization of the disorder. I mentioned at the beginning, the metastructure that ICD and DSM group agreed on how they're structured. The metastructure, which is how things are grouped together, was informed by things like High Top, the way things group together. So I think certainly dimensional approaches will inform revisions of the DSM and the ICD, and that's one evidence of, including substance dependence. But I think having an entire system like High Top be usable by clinicians is, I think, a real challenge.
In WHO in particular, the mental disorders section is a part of the overall ICD, which is meant to cover all health conditions and is a categorical system. So that's the rules that we operate under. And so we have really tried to incorporate certain kinds of dimensional concepts into the way that the categorical system is laid out. The example that I talked about being personality disorder, but we can't have a system for mental disorders that operates in a completely different way than the rules of the rest of the classification, because that wouldn't be acceptable from WHO or anybody's point of view. DSM could theoretically do that because they're not bound by the same requirements in terms of the rest of the medical diagnoses.
Yeah, but clinicians are bound by the need to do categorical diagnosis. So
yeah, right.
I think DSM would have a real hard time moving totally in that direction.
So another question that came up, this is from Harold Pincus, was whether you could comment on how the financial or incentive structures differ across DSM and ICD, and whether that exerts any influence.
Well, they're quite different. I think everybody is aware of how much money the APA makes from sales of DSM. WHO makes no money off the sales of. In fact, the cost. Now, APA will say, well, the money that comes into DSM was used for the revision. ICD had to struggle the entire revision process getting money. It's a real big problem. Had WHO made a lot of money off the classification, it would make the revision process much easier. So it's really very, very different. So that does have some impact on, I'm not sure it affects decisions per se, that decisions are made specifically to sell books. But I think that perhaps one of the reasons why APA would be not enthusiastic about just dropping the DSM franchise and switching over to ICD would be a huge loss in financial take.
It's also, I think one of the things that sets a real ceiling on harmonization, because, so I used to see sometimes these, APA officials kind of wringing their hands about why do we have two separate classifications? And it's like, well, if you don't want two separate classifications, there's an obvious solution. But that just won't happen, because if the two systems were completely harmonized, why would you buy the DSM when the ICD was available to you for free? So I think it does have a impact in that way, and it's one of the reasons that I don't expect that we will ever see two systems that are identical.
So the next question is from Prudence Fisher, who writes in, ICD-10 had the clinical version descriptive, as well as a research version. DSM seems more like the research version in terms of specific rules, counts, etc. Is a research version being prepared for ICD-11?
So let me talk about this first, and then I'm going to refer to Michael in my response, so then he can talk about it. So from what we have been able to tell, the ICD-10 research version was used in research not at all. There really, like maybe 2 publications that use the ICD-10 research version. Its primary use was actually that training programs use the research version because it was easier to use than the clinical descriptions and diagnostic guidelines. And so it was a kind of, DSM light in terms of its corresponding to the ICD-11 categories being very similar in terms of the degree of operationalization. One of the things that we really have done, and Michael and I have worked on this a lot together, is to really make the material in the ICD-11 be very consistent across categories and be much more clinically useful. So we don't tend to say there needs to be 3 symptoms for 4 weeks. It tends to be more flexible than that to allow for cultural variation and clinical judgment and different patterns of care. But it is, I think, in some ways similarly specific. When we think about a research version, if a research version is going to actually be used, you need to ask the question about research for what. One of the ways that research would be used would be the epidemiological surveys, and the CD is actually a WHO instrument, and so the CD will have to be modified to include the ICD-11. We've also been working with Michael for several years now on developing a structured clinical interview for ICD-11, which would be suitable for other types of research. The scan has been modified to be suitable for ICD-11, and we expect to develop other kinds of measures that would also be self-administered paper and pencil measures. So I think rather than saying that there's a research version, because you wouldn't really use the same exact thing for an epidemiological survey as you would for a pharma trial, that we would have different kinds of tools for researchers that are based on the ICD-11 and then operationalized as necessary for that particular purpose. So in an epidemiological survey, you have to have all the questions be completely closed-ended and all be yes and no, whereas in the structured clinical interview, the clinician has to make interpretations about whether the particular symptom is present or not. Michael, do you want to add to that?
The other thing I'll add is conceptually, the research version was created for ICD-10 to facilitate researchers using that system as opposed to the DSM. So if the goal is facilitating the use of the system, then our strategy is let's create the tools, because the researchers need the tools. Having a book of criterion-aided definitions is not what they need. So that's why the structured interviews have been created, and we're also coming up with a rule book based upon when we created these structured interviews, we had to convert this, some of the following to actual numbers. So in a way, that's sort of the consensus research version is operationalizing these thresholds so they can be used in research assessment.
So I wanted to ask another question. It was really interesting for me to hear Dr. Reed's discussion of pediatric bipolar disorder, particularly because when I was training in child psychiatry, that was sort of during the intense aspect or intense parts of that debate. And I remember well in child psychiatry clinics at that time, almost every other patient would come in with a diagnosis of pediatric bipolar disorder and be on neuroleptic. And there was, when DSM-5 came out, as you alluded to, there was a lot of hope that this new DMDD diagnosis would help alleviate that and alleviate concerns about overdiagnosis of pediatric bipolar and overprescribing of neuroleptics. And I guess I'm wondering, do we know the extent to which that has really played out? What's happening to the rates of pediatric bipolar and related neuroleptic treatment?
Answer is I don't think so. I mean, I'd love to read that paper. I'm sure people are looking at it, but we're not aware of whether or not this fix actually achieved its goal.
Mm-hmm.
One thing that I would say, though, is that DMDD is much more likely to be medicated than ODD with chronic irritability and anger, because medication is not generally viewed as an appropriate treatment for ODD. Whereas because you have put DMDD in the mood disorder section, it's kind of an invitation to medicate it. So I have seen indications that there's quite a fair amount of off-label use of SSRIs and methylphenidate and risperidone for DMDD. So I'm not totally sure that it's solved. Maybe that's all totally appropriate. I mean, I haven't seen trials, but perhaps these kids respond well to SSRIs. So I'm not saying all that practice is bad. I'm just saying there's more potential, I think, for over medication under the DMDD diagnosis than there would be under the ODD with chronic irritability and anger.
Although I guess arguably, if you're going to see over prescribing, it's probably better to see over prescribing of an SSRI than a neuroleptic.
Absolutely,
Yeah,
right. Yeah.
Okay, so there's a question from William Tucker, who writes in asking whether all professionals are able to pick and choose from the two types of diagnostic symptoms and diagnostic systems. And he gives the example of a defense attorney invoking ICD versus DSM, depending on how it may play out in the court.
This is something I've had discussions, especially about these paraphilias. And so the definition of paraphilia is a little bit different, and whether or not, or excessive sex, like the fact that DSM, ICD has a compulsive sexual behavior disorder. Could you make that as a diagnosis for a court case? And I think the answer is probably not. There's this idea of the concepts that you present, an expert presents, have to be widely accepted by the field. And I think the field is the field in the United States. So I have a feeling an attempt to pull out an ICD-11 diagnosis in a case in the US courts could easily be defeated by the other side by simply pointing out that this is not a system that's widely used.
Defense attorneys can obviously try whatever they want, but how likely it is to succeed is another issue.
Great. Okay.
The other thing I would say about this, though, is that the actual reporting system that's required in the United States is the ICD-10-CM, and the DSM-5 does offer you ICD-10-CM codes that translate the ICD and the DSM categories into that coding system. But if you look at the ICD-10-CM, it isn't the same as the DSM. And if you were a clinician and you said, well, I'm going to use the ICD diagnostic guidelines, I think you would have trouble with insurance companies. But in terms of the ICD-10-CM, I don't think there's an a priori reason that you wouldn't be able to do that.
Well, except for the fact that when implementation of ICD-10 in the US, ICD-10-CM, they've deleted categories that are in the WHO's ICD-10, so the codes simply aren't there. So they actually, and that was guided a lot by what APA wanted.
Yeah.
So I think this will likely have to be our last question. This is from Mike Grimbaum, who points out that some studies are using the mini instead of the skid because it's much faster to administer, and asked if you could comment on the contrast between the mini versus the skid in terms of reliability and validity, and maybe just for our audience also, if you could talk a little bit about the differences between those two instruments.
Sure. I've obviously extremely biased in favor of the skid over the mini. The one study that I'm aware of that was done to really compare the mini and the skid showed, as you might expect, that the mini has a much higher false positive rate. And the reason is very simple. The big difference between the mini and the skid, for people so both of these are diagnostic interviews. The goal of each of these instruments is to be able to make a DSM diagnosis. The core design feature of the skid is the actual DSM criteria are right in the center of the instrument in your face. And your job doing the skid is to say, is this criterion met using the questions we've given you? There are no criteria in the mini, it's just questions. So and in order to do this, so they basically paraphrased a lot of the criteria, and they did them so that they're yes, no questions. So the mini is primarily questions that can be answered yes and no. So that really created a validity. The mini is closer like to the CD or the DIS, which is something which is a yes, no. So there's an inherently less valid when you do it that way. Now, theoretically, it should be more reliable than the skid because it's more closed-ended, but I'm not aware of any evidence that shows that the mini is actually more reliable, but I'm pretty sure it'd be pretty clear that it will be less valid.
Okay, great. So I think we'll stop with that. And again, I really wanted to thank Dr. First and Dr. Reed for that incredibly illuminating talk and really interesting discussion. And I hope everyone can join us again next week to hear from Dr. Sweet from University of Pittsburgh. And so with that, I hope everyone has a good day.
Thank you very much. Bye-bye.